keep your mental health muscles strong with the Emotional Badass Podcast. I'm Nikki Eisenhower, your host, psychotherapist, and life coach. The Emotional Badass Podcast is your place to learn the mental health tips and tricks you need to build emotional resilience and practice mindfulness and gratitude. Join me every week for new episodes to reach a more grounded state of well-being as life brings its challenges. Search for Emotional Badass wherever you get your podcasts.
Well, hi there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. So today we are diving into pharmacology. And before we do that, let's take an eensy minute for a listener shout out. And this one goes out to Tasha, who says this: I bought Fast Pharm to study for the NCLEX, and I am so glad that I did. I felt confident on meds. Aside from the improved confidence for the NCLEX, I generally have a better understanding of the medications covered in Fast Pharmacology. Thank you very much for creating this course. It is completely incredible. Tasha, thank you so much for taking time to share how Fast Pharmacology has helped you pass your NCLEX and is helping you as a nurse. So if you're wondering what Tasha is talking about, Fast Pharmacology is an audio-based program. So you're listening to this podcast, you clearly like audio learning, which is why I made Fast Pharmacology in that format. And what I do in that program is I explain pharmacology concepts and more than 80 drug classes in lessons that are 5 minutes or less. Yes, 5 minutes or less. So I will put a link in the episode notes if you want to check that out. I highly encourage you to do so. It's fabulous for nursing students at the beginning of their journey. It's great for prepping for NCLEX, and it's great for working nurses who just want to brush up their pharmacology knowledge. Go to straightanursingstudent.com/fast to check it out. Okay, so what are we talking about today? What topic of pharmacology? And that is calcium channel blockers. So let's go through a couple of patient scenarios, just very simple patient scenarios, because I want to illustrate that calcium channel blockers are used for a variety of different things. So patient number 1 is Lloyd. Lloyd is a 48-year-old male patient who consults his primary care physician for a routine physical. His background is that he has a history of asthma, eczema, GERD, obesity, and IBS. His assessment findings reveal a heart rate of 78, a blood pressure of 162/92, respiratory rate 16, SpO2 is 96% on room air, and temperature is 36.9. So what's abnormal here about Lloyd? It's his blood pressure. 162/92 is definitely elevated. So the MD diagnoses Lloyd with stage 2 hypertension and prescribes the calcium channel blocker amlodipine. She provides education on the DASH diet and, of course, encourages Lloyd to lose excess weight, since excess weight is a big contributor to hypertension. Lloyd is scheduled for a follow-up phone appointment in a couple of weeks for evaluation and possible dose adjustment. So that's patient 1, Lloyd, who has hypertension. And then patient 2 is Sandy. She's a 55-year-old female patient who visits the urgent care clinic for intermittent palpitations and feelings of lightheadedness that have been occurring for about the past 3 weeks. For her background, she has a history of migraines, uterine fibroids, and hyperlipidemia. Her assessment shows a heart rate of 123, a blood pressure of 118/72, a respiratory rate of 17, SpO2 is 97% on room air, and temp is 37.1. A 12-lead EKG shows atrial fibrillation. So the MD diagnoses Sandy with paroxysmal atrial fibrillation, meaning it comes and goes, and she prescribes the calcium channel blocker diltiazem along with an anticoagulant. She refers Sandy to a cardiologist for further evaluation and management. So, what do these two patients have in common? They were both prescribed a calcium channel blocker, but for very different reasons. So, what are calcium channel blockers? Calcium channel blockers, also often abbreviated as CCBs, are medications that are used to treat hypertension, angina, and certain tachyarrhythmias, including atrial fibrillation and supraventricular tachycardia. They exert their mechanism of action in a few ways. So one is CCBs block the influx of calcium ions into smooth muscle and cardiac cells. That makes sense, right? They are calcium channel blockers. So they're blocking the influx of calcium into the smooth muscle and cardiac cell. In smooth muscle, what this does is it leads to vasodilation. And in the cardiac cells, this leads to decreased contractility. Calcium channel blockers also decrease conduction from the SA node to the AV node. And you can probably guess that that slows the heart rate. So let's look at the three key problems: hypertension, angina, and tachyarrhythmias, and highlight a little bit how CCBs help. So looking at hypertension, how a CCB helps hypertension is by causing vasodilation. Vasodilation decreases peripheral vascular resistance, and when peripheral vascular resistance is decreased, what do you think that does to blood pressure? It causes it to go down. Another problem is angina. So when PVR, or peripheral vascular resistance, is decreased, do you think the heart has to work as hard to pump? No, it doesn't, because it doesn't have as much pressure that it's pumping against. So if the heart doesn't have to work as hard, this decreases myocardial oxygen demands and reduces occurrences of angina. And then CCBs also cause vasodilation of coronary arteries, which reduces incidences of angina in that way as well, including angina caused by coronary artery spasm. So angina can be related to coronary artery disease, and a lot of times it's brought on by exercise, and then it's relieved by rest or nitroglycerin. We call that stable angina. We're going to use a calcium channel blocker for stable angina. And then another type of angina is caused because the coronary arteries themselves are spasming. It can also help with that type. If you want to take a little detour and learn more about angina, take a walk back in time, head over to episode 62 of this podcast, and you can get a little overview of the 4 key types of angina in that episode. And then the third key problem that CCBs help address are tachyarrhythmias. So calcium channel blockers block the influx of calcium into those excitable cardiac cells, and that reduces heart rate. CCBs also slow conduction at the AV node, which also slows the heart rate. So that's why you'll see them used for atrial fibrillation with a rapid ventricular response and supraventricular tachycardia. So in our scenario with Lloyd and Sandy, they were both prescribed calcium channel blockers, but they were different calcium channel blockers. One got amlodipine and one got diltiazem. And the reason for this is that there are 2 types of calcium channel blockers: dihydropyridine and non-dihydropyridine calcium channel blockers. So let's talk through each of these types, but first let's take a very quick break, let everything you've learned kind of soak in, Then we'll come back and talk about the 2 types of calcium channel blockers.
Emotional Badass is the weekly mental health and wellness podcast dedicated to empowering you with the emotional education so many of us crave. I'm Nikki Eisenhower, a psychotherapist with expertise in talk therapy, personal growth, and therapeutic healing. Join me every week on the Emotional Badass podcast as we delve into the heart of emotional wellness, tackling topics from stress management and coping strategies to the nuances of being highly sensitive. We navigate life's challenges, uncover the subtleties of gaslighting and manipulation, and confront narcissism head on. All the while, we learn to forge healthy boundaries that enrich both our personal and romantic relationships. With brand new content every Sunday and over 300 past episodes in our archive, there's something for everyone. Search for Emotional Badass wherever you get your podcasts.
So there are 2 types of calcium channel blockers, dihydropyridine and non-dihydropyridine. So let's first talk about dihydropyridine calcium channel blockers. This type primarily acts on the blood vessels, causing that vasodilation. And this type is mainly used to treat hypertension, which is why our patient Lloyd is taking it. You will also see them used to treat stable angina and angina caused by coronary artery spasm. A commonly used dihydropyridine calcium channel blocker is amlodipine. And a really easy way to recognize these medications is they end in pine or P-I-N-E, amlodipine, nifedipine, nicardipine. These are all going to cause that vasodilation and work more on the blood pressure. And we use these for hypertension, but we also use them for angina, as I mentioned above, how and why that works. So that's the first type. The second type I mentioned is non-dihydropyridine calcium channel blockers. And these are mainly used because of the inhibitory action they exert on myocardial cells to reduce heart rate and slow conduction at the AV node. So can you guess what this type is used for? This type of calcium channel blocker is often used to treat arrhythmias, such as atrial fibrillation with a fast ventricular rate and supraventricular tachycardia. And that's why our patient Sandy is taking it. You may also see this type used to treat angina as well. Common calcium channel blockers of this type are diltiazem and verapamil. Unfortunately, they don't have a naming convention like the other type does, so you just have to memorize these. Again, that's diltiazem and verapamil. Note that though the 2 types are primarily used for different purposes, again, dihydropyridine calcium channel blockers like amlodipine are mainly used for hypertension, and then non-dihydropyridine calcium channel blockers are mainly used to slow the heart rate. They still share pharmacologic characteristics. So even though amlodipine mainly acts as a vasodilator, and we're going to give it to Lloyd for his blood pressure, it's still going to have some effect on heart rate. And even though verapamil is often used to reduce heart rate, it does have some vasodilatory properties. So keep this in mind as you are administering these medications or considering them as you're working up a care plan if you're a student, because if you're giving somebody amlodipine, of course you're going to measure their blood pressure, but you're also going to want to check their heart rate because it could have some effect and slowing of the heart rate. And if you're giving verapamil or diltiazem to a patient because they have atrial fibrillation with RVR or rapid ventricular response, then you're going to be checking their heart rate, but you're also going to be checking their blood pressure because it could have some vasodilatory properties there. And then, of course, if you're giving it for angina, whichever one you're giving, that effect is going to be more pronounced. But again, you're looking for both heart rate and blood pressure. So now let's look at an example of how a calcium channel blocker is used for angina. We talked about hypertension with Lloyd. We talked about a tachyarrhythmia with Sandy. Well, now we have Randall. Randall is a 67-year-old male patient who visits his primary care physician to discuss his periodic episodes of chest pain. And he basically says, by the time I get to the ER, doc, the pain has stopped, so I just go home. So Randall's background has a history of coronary artery disease. He has type 2 diabetes. He has hypertension and BPH. So we take his vital signs. He has a heart rate of 64, a blood pressure of 138/72, a respiratory rate of 22, and an SpO2 of 98% on room air, and his temperature's fine at 37.2. At this time, Randall is not having any chest pain, but we do a 12 lead anyway, and it shows sinus rhythm with no abnormalities that would suggest a current or even a past myocardial infarction. Basically, he tells the MD the pain occurs when he's doing stuff around the farm, and then it eases up when he stops and rests. So the MD diagnoses Randall with stable angina and refers him to a cardiologist for further evaluation. So which type of calcium channel blocker do you think will be prescribed for Randall? Is it going to be the dihydropyridine calcium channel blocker like amlodipine? Or is it going to be a non-dihydropyridine calcium channel blocker like diltiazem? Well, now that you know a little bit about the two differences, it might make sense to learn that the MD prescribes amlodipine. And why is that? Because amlodipine is going to have the least amount of effect on heart rate. Because look at his heart rate, it's 64. It's not bradycardia, but it is borderline. If we gave him diltiazem, the risk for bradycardia would be much, much higher. We definitely don't want that. So Randall's getting a dihydropyridine calcium channel blocker like amlodipine for his stable angina. Good job. So a few nursing implications before we close out so that you understand giving these medications safely and the things that you want to teach your patient. So first of all, you're monitoring blood pressure and heart rate before you give the medication and after you give the medication. You want to watch for serious adverse reactions, which can include dysrhythmias, significant bradycardia, especially with something like diltiazem. Heart block can occur, and so can heart failure. So a lot of times, and maybe even most or all of the time, these medications are avoided in patients with bradycardia, with heart block, and with heart failure. It can also cause Stevens-Johnson syndrome. You want to watch for something called reflex tachycardia, which can occur with dihydropyridine calcium channel blockers like amlodipine and nifedipine. And this occurs as the heart rate is trying to compensate for that vasodilation and the hypotension that can result with these medications, which I know seems counterintuitive. We're giving it to decrease the blood pressure. Why is the body kicking in and trying to increase the blood pressure? But it can happen. Reflex tachycardia. There is something called calcium channel blocker toxicity that can occur. And when this does occur, it causes profound bradycardia and hypotension and possibly even a heart block. So a patient experiencing calcium channel blocker toxicity will need continuous ECG monitoring. They'll need medications to increase heart rate, possibly also medications to cause some vasoconstriction and increase blood pressure if increasing the heart rate alone doesn't help, and possibly external pacing. And then some key things to teach your patient include you want to make sure they know how to measure their heart rate and their blood pressure at home. Lots of times, or most of the time, these patients will have a little home blood pressure monitor. Teach them how to use it. Teach them how to measure their pulse or their heart rate. And then you also want to teach them to avoid grapefruit juice because calcium channel blockers is one of those meds that do not play nice with grapefruit juice. And what happens is grapefruit juice can increase the plasma concentration of calcium channel blockers. And what would that lead to? That would lead to calcium channel blocker toxicity. And we already know we definitely don't want that. So there you have it, an overview of calcium channel blockers, the different types, and how they're used and why they work. So if you enjoyed learning about pharmacology while listening to me talk in your ear, then you're going to love Fast Pharmacology. I definitely want you to check that out. I do cover calcium channel blockers in that program, of course, in 5 minutes or less, along with 80 drug classes. So I'll name a drug, it's probably in Fast Pharmacology, as well as some key pharmacology concepts like pharmacokinetics, pharmacodynamics, all that stuff that might seem kind of boring and you might gloss over it in class because you just want to start learning about drugs. But these things actually set your foundation for understanding how all of this works in the body. So go to straightanursingstudent.com/fast to check out Fast Pharmacology. And then I, of course, want to see you back here next week. We're going to do a quick breakdown of the different types of hepatitis, because I know this comes up on exams. And even now as a nurse, I'll get a patient and they'll have a type of hepatitis and I'll think, I remember learning about this. Now, what was it with that type? And you know what? It's always just nice to get a review. Even if you've been a nurse forever, I always say we're always students because we're always learning. So come back and join me next week where we talk about the different types of hepatitis. See you then. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Keep your mental health muscles strong with the Emotional Badass Podcast. I'm Nikki Eisenhower, your host, psychotherapist, and life coach. The Emotional Badass Podcast is your place to learn the mental health tips and tricks you need to build emotional resilience and practice mindfulness and gratitude. Join me every week for new episodes to reach a more grounded state of well-being as life brings its challenges. Search for Emotional Badass wherever you get your podcasts.